distinguished guests. The first is Dr. Bronwyn Jenkins, neurologist from Sydney, undergraduate training in Newcastle. Her private work as private practice was a subspecialist interest in headache, as well as running the headache clinic as an honorary medical officer at the Royal North Shore Hospital. She's written a postgraduate course in headache for the University of Sydney with ongoing interest in headache education. She's an assistant editor for Kefalgia and active in publications relating to headache. She's immediate past president to the ANZ Head and Neck Society, member of the ARCH, IHS, AHS, and been co-opted member of the International Headache Society Board from 2018 to 2020, with continuing education, leadership, and ethics subcommittee roles in the International Health Headache Society. So without further ado, Bronwyn, the floor's yours.
Thanks so much. I was really excited about doing this talk, mainly because I could call it, oh, how's it going? When it's not the sinuses. So I hope you haven't heard that every single time you get someone external talking. I think headache's a really exciting field, and there's more reason than ever to recognize when it is a primary headache disorder. So that's what I'm going to primarily focus on. And then Rob will talk about other sort of facial pains that are probably more weird and wonderful and interesting. But it's amazing how underdiagnosed, undertreated it still remains, just even common barn door migraine. So obviously the sinuses and migraine are often comorbid in their symptomatology because they have convergence on the one pain center. A bit of a bad design, I tell my patients, seeing as we have all these, individual corpuscles to tell us what our fingers are doing, and we have just one pain center in the brain. And there was the most recent study looking at the rate of sinus congestion symptoms in headache was in 2020 that I could see. This was an Asian study, which was important because that hasn't been done. And cranial autonomic symptoms, including sinus congestion, were quite common. So 42.4% in other headache disorders. And so this was of migraine. And so you can see the little chart there showing things of interest to this group: oral fullness, nasal blockage, rhinorrhea. And so it's really still quite very common to have these cranial autonomic symptoms in this group. And that group had more severe headache, more sensitivity to noise and light. And so all the people are over the bottom of my slide, and more cutaneous allodynia. So people get very concerned about their sensitivity over the scalp, but really it just means that they've got a chronic high frequency headache disorder usually. So you guys are seeing the worst migraine sufferers. And so because of that, it's good to know what to do with them. So I'm going to tell you everything. So the ABC. So I think the first thing is how to assess someone. And so it all comes down to history. So if it doesn't smell right in your world, it's possibly my world, and the same vice versa. But we always look for red flags. So rather than skipping over this, I thought I really like this flow chart, because if you've excluded red flags, and there's still atypical features, you go back to reconsidering whether there's a secondary headache or problem underneath causing the headache. And the simplest mnemonic, not that it's that simple, is to have this Snoop 4 category. So if there's systemic stuff, symptoms, signs, fever, weight loss, other illnesses like giant cell arteritis, malignancy, HIV, neurologic symptoms. So if they're encephalopathic or whatever, that's an acute emergency, and sudden onset, a postural or orthostatic headache. I love the way they have three O's essentially. Older onset. So if you have someone who really truly swears that their first headache's been above the age of 50 years, the generic dog barking. Sorry, everyone. If they're over 50 years for their first headache disorder, it's not a primary headache disorder. Usually you can tease them out if they used to have headaches with hormonal changes, alcohol, typical triggers. And if it's nihilistically progressive, so people come in worried they've got a brain tumor, but those patients, they really have progression rather than this fluctuating variable episodic nature that we get in a primary headache disorder. Unfortunately, even if they've got migraine, headache is a symptom in all of our worlds. So if they have a progressive headache with loss of headache-free periods, if it's precipitate Valsalva, like doing a poo, coughing, cheering, not many people cheer these days, which is a shame. But anyway, postural aggravation, although most headache people get worse bending over. But if they're propping themselves up in bed overnight, that's not normal. Papilledema, obviously, and pulsatile tinnitus is really worth asking about. Then you'd want to be doing, at a minimum, some investigation and imaging. So, sorry, it's not progressing. Okay, we go. So I do basic blood tests, deficiencies, B12, thyroid, iron, an inflammatory marker, usually the CRP, particularly in the elderly, to make sure we haven't missed giant cell arteritis or something like that. It's rare that I do a lumbar puncture, and an MRI is much more sensitive, but not every Australian with headache needs to have imaging because you find a lot of false positives. So, my approach to headache, this is really what I wanted to talk to you about. So, if you have found that it's not a sinogenic pain, then the things you're looking at in the primary headache world is tension type headache. They rarely go to doctors because they can run around the block, distract themselves, and get on with life. They don't have associated features. It doesn't limit them, doesn't intrude in their day. It's usually a milder headache. So, whilst that's the most common type of headache disorder around the world, it's the least common, and I rarely see it. I wouldn't even see one tension type headache patient a week. Whereas migraine, because on occasion it can be worse, there creeps in this fearfulness about the next attack. It demands treatment. It limits activities, whether it's full exertion or whether it's actually leading to resting in bed. It's still enough to go to a doctor about. And then we've got the weird and wonderfuls, trigeminal autonomic cephalalgias, which we won't talk too much about. And they're things like cluster headache. And a new daily persistent headache, which I think, starts on a day. It definitely gets to its peak within the first week. And so some people go into this daily pattern after getting worse and worse and worse over years because they don't want to take medications or see doctors. But a new daily persistent headache is worth knowing about because you can have glandular fever or COVID infection or no real reason at all and have this new headache that started on one day. And they will literally come in and say, I have this headache. It started 424 days ago in 2023. And you go, okay. And they can be migrainous in character and still respond to our treatments. So the key of this talk is to tell you some really useful, simple things. So in my practice, I have a nurse to help me limit my time taken up by seeing new patients to streamline so I can stay open to new patients. Because with all these great treatments, we want to see them, we want to sort them, we want to send them, we want them to have a better quality of life function and improvement. So she uses this screening tool and it's got a high rate of sensitivity and specificity. So if you're asking a person if they have their activities been limited for a day or more over the last 3 months, were they nauseated or sick in their stomach, and does light ever bother you? Then if they say yes to 2 of those 3, it's highly likely they have migraine disorder. So in Australia, we still expect people very much to be lying in a dark room, vomiting into a bucket for some of their attacks. But I think the people we're looking at are often, they don't have absenteeism, they have this thing called presenteeism where they're making it to work, but they're sort of not the full quid and they're limiting some activities. They'd cancel dinner, they'd not go to the gym that day. And so it's really important to not have this stigma of what migraine should look like. The criteria are really well defined in the international classification, but I think the most interesting thing is you don't need a full hand, and you certainly don't need a full hand for every headache disorder, a headache attack. So it only needs 2 of the features and 1 or more of the associated features. So you're not looking for someone who has your most amazing, I would teach medical students, type migraine disorder before you call it a migraine and recognize that it's a significant headache they've come to see you about that warrants treatment and therefore give them the opportunity of improving on the disease-specific and other treatments. So yes, it's nice if it's unilateral, pulsating, moderate or severe on occasions, and it should be moderate at least. And I find that asking them about exercise is the most specific question. So if they say, oh, when I have my worst headaches, I would go for a run, that's not usually typical of migraine. Whereas if you say, like a lot of my colleagues do, when you have a headache, do you have to rest in a dark room? Most people will say no. But if you say, when you have a worse headache, would you avoid doing too much exertion, like maybe limit going up, running up a flight of stairs? And they say no, then that's a more sensitive question. So you've got to pick how you ask the questions. So, I won't go on too much about this, but yeah, preference to rest rather than complete need to rest. Just to touch on the tax headaches, because you'll see them a bit when someone's got unilateral symptoms and they swear that it therefore must be sinus. These are really interesting, and they'll get a tearing, red, drooping eye. They'll get sensitivity. It'll be an orbital pain. And they're really classified based on the duration of the attack. So cluster headaches are a classic one that usually goes 15 minutes to 3 hours. And then we've got these super brief ones that are just a stabbing headache that lasts for seconds to minutes. And then we've got paroxysmal hemicrania, which last up to half an hour. And so you don't want to miss them because some of them have specific treatments. So cluster headaches, we call it suicide headache because it's awful. They get agitated. It's a medical emergency, really, to get them seen and sorted. They're very hard to treat. I'm very heavy-handed. I do gon blocks, give them crazy doses of verapamil. We used to give them steroids. We don't so much. Multiple medications, rescue medications, home oxygen, whatever. So I think it's useful to go, oh, this could be cluster headache. And send them along. They typically are seasonal and come in runs and then go away for most of the year. They typically occur in the majority of men, and they usually start as a nighttime attack. So certainly don't send all your patients that might be cluster headache that have 3-day barn door migraines, but they had some unilateral cranial autonomic symptoms, because we already know that happens a lot from the first couple of slides. But certainly if you see someone that's like, these are really brief, severe attacks and their partner's worried about their survival of how severe these attacks are, then do send them to a headache specialist with a degree of urgency. But the other ones on that chart of the shorter ones are really exquisitely sometimes indomethacin responsive. So paroxysmal hemicrania and hemicrania continua, which is actually a long, and it's now in the tax headache since that first picture was drawn. They're only responsive to indomethacin. They're not responsive to diclofenac, which is Voltaren. They only respond to this. And so knowing that, again, gives the opportunity of giving them 2 weeks of that at a decent dose and curing them of this headache as long as their gut can tolerate it. And Sungtans Duna are weird. Let me know if you see one, because they're so weird and wonderful. They're really unusual. So I won't go on about them. So we've got a simple screening tool to try and delineate migraine, because that'll be the most common thing you see. Tension type headaches, unless they want to chat, won't come and see you. And now, really, why does this all matter? Why do we need to differentiate between headaches? Aren't they all just primary headache disorders? And I think, like I said at the beginning, it's really important because now there are amazing treatments. So the principles of migraine management, there's sort of essentially 3 things we do. One is acute treatment. One is we talk about triggers and lifestyle management, because that's what patients are sort of quite motivated to control. And the third is, along those lines of decreasing the frequency and severity, is preventive therapy. And preventive therapy in migraine, like a lot of conditions, is not disease modifying. You give it to them, they're not better next year. But you give it to them, they're better that month. And if you can decrease the frequency and severity, you suddenly put these fearful, terrible attacks that stop them functioning or just being nice, and it can make it a manageable headache that they get to work with and do all the things they want to do. So overall, we're aiming to reduce headache days, obviously, headache duration and headache intensity and severity. And luckily, there's a lot more interest in actually also just reducing the most bothersome symptoms of sensitivity to light and noise and nausea. And I think the preference to rest should be on there too, because really they're the things that get them and mean that they can't look at a screen and can't tolerate usual sort of household activities or anything really, rather than just the headache severity, which some people are pretty tough at managing. So these things are complementary. It's not an either or. You don't get to just take an acute medication or just be on a preventive medication. Both of them complement each other, as well as treating the person as a whole person and, not ignoring their iron deficiency and their hypertension and their terrible insomnia, their sleep apnea untreated, all the factors that play a role. So, along the lines of acute treatment, I give my patients a plan that says you can use any one of these classes together, but not all things from the same class so that you're not overdosing. So basically, if they've got some nausea or altered appetite, they're probably not absorbing their medication. If they can treat a milder headache with paracetamol and an anti-inflammatory, that's all well and good. We typically use ibuprofen, which actually doesn't get across to the brain very well, so we often step them up to something stronger. And these days, we'd also sometimes throw in paracetamol and caffeine. An aspirin bomb would be 3 aspirin, paracetamol, and caffeine if it's early enough in the day. But really, the most effective medication would be a triptan, which is blocking the migraine pathway. And so there's 5 of them in Australia. And they're now over the counter. So you can get boxes of 2 of these triptans for people that don't have cardiovascular disease. So that's really the main warning that you shouldn't be giving to people that are at risk of having problems if you caused vasoconstriction, because they can do that. Sometimes they're vomiting so severely you need suppositories or other things. We have very few injections or nasal sprays gone out now in Australia, sadly. So they're really tricky. This is quite an old plan, and it had, this patient had even tramadol. We hate narcotics or anything along those lines because the risk far outweighs the benefits. But there are some people, if they can't take a triptan, for instance, might need that. So that's the acute treatment. So really, it's quite heavy-handed to give them a whole range of things. The preventive treatment has come a long way in the last 20 years. So we generally offer it to anyone who's got more than 4 significant migraine days a month. Or it can be someone who's got less than that and they're impossible to treat migraines that are, fearsome. So we choose the oral preventives largely based on their comorbidities. So if they've got hypertension, use a blood pressure medicine. If they have low blood pressure, don't use a blood pressure medicine. And also the potential for side effects and interactions. So if they're morbidly obese, don't give them something that increases their appetite, but you might choose topiramate that decreases appetite. So it's not a great way to choose your medications, I think, to be based on their side effect profile, but the oral medications are all borrowed from other classes, and they do come with a list of side effects each, which are really well delineated in the electronic therapeutic guidelines and tools like that. I'm not expecting you to have to start preventives, but just so you know the background of why you're sending them to a headache specialist, for instance. Recall is really poor. So it's easier, I think, in your field of like they know how long they've been sick for. But when it's an episodic migraine disorder and they're telling you how bad their January was in July, they really can't remember what all that meant. So a simple diary like this, where they circle or square and the worst days and they dot the little days, tells you the overall frequency, but also tells us the worst days, and then they cross it out if they get rid of it in an hour or two. So I think that a diary is as important for our patients as it is for us. This is the therapeutic guidelines. They're being updated at the moment. They should be out any month now. So I access them through CAP. It depends which server you've got to, but they're really useful because they tell you all the doses and duration. And we usually measure their success at 8 to 12 weeks because nerve stabilization takes a while. So there's the list of side effects on the right, which is the most obvious compared to the class and the medication treatments of the Sentinel most commonly used migraine preventives. So it's a bit of a hard sell, and the compliance rate is quite low because of risk of side effects. So you have to tell them what to look out for and then get them back if they're not tolerating it. Oh, interesting. There you go. I've flipped this picture back to front, so anyone who can read that gets extra points. So Botox is not, if they fail 3 preventives or they can't have them because of interactions or they had terrible side effects, then they qualify if they have 15 days a month of headache, of which 8 are migraine. They qualify for Botox or a CGRP injectable, which are more effective treatments. They've rarely gone head to head with orals, but they are more effective in my practice and in those studies that they have done. So everyone thinks Botox is about muscle relaxation. So I constantly have people being sent to me because they've got a sore neck. So therefore consider Botox. The more they rely on the Botox for muscle relaxation, the more they miss it when it wears off because they can only get it 12 weekly on the PBS based on the headache studies. It's really about blocking this back to front neurotransmitter picture over here about the release of the neurotransmitters involved in migraine. I'm a talker, not a doer, but I do Botox for my patients because it really helps. And they happily bounce back in every 12 weeks to have it done indefinitely. So the CGRP antagonists are the most useful treatment, the most important neurotransmitter we're blocking. Really well tolerated. The only thing to tell them about is redness at the site of injection or itchiness and constipation usually. We wouldn't use it in unstable cardiovascular situations, but because it blocks dilation rather than causing vasoconstriction, if you're looking at someone who can tolerate a triptan, they can tolerate a CGRP treatment. And all the studies were positive. I have a massive number of people who are more than 75% responders in their migraine days, suddenly no nausea, able to treat them paracetamol, never missing time from activities, doesn't come back at them. It's extraordinary how this improves their quality of life and function. So having disease-specific preventives, like we have disease-specific acute treatments, has been life-changing. And no one walks around town talking about life-changing. You don't go to a school reunion and everyone talks about life-changing, but our patients do talk about life-changing. And so really, if you take one message home, is if you're looking at someone who's suffering with headache enough to come and see you, try and get them back into care to treat their primary headache disorder if it's not something that's under your domain. So I think consider red flags if it's not due to their ENT issues. Particularly be worried about in atypical cases, the elderly or unwell patients. So, don't take it lightly if they've got cancer as well. Usually a diagnosis of the headache disorder is important to determine their best management. And so there's simple screening tools and really easy to remember diagnostic features, but they don't have to have all of them. And in migraine, try disease-specific treatment, whether it's acute triptan or whether it's the preventive CGRP antagonist when they qualify for it. So I hope that's helped. It's everything I do all day in 20 minutes or so. So a bit of a rush, but if you took away one or two things from that, I think you'll help and change a lot of lives. So thanks for having me along.
Thank you very much. All right, do you plan to stay on, Bronwyn? Should we move
Yeah,
to Rob's talk and then maybe we could have discussions after if anyone wants to ask questions?
perfect.
Cool. So our next speaker is Associate Professor Robert Delcanho. He graduated in dentistry in 1978 from Western Australia, and after 14 years in dental practice, completed 2 years of orofacial pain residency and master's degree in orobiology in UCLA. After returning to Australia, he commenced practice and restricted to orofacial pain and temporomandibular disorders in dental sleep medicine. Rob is a diplomate of the American Board of Orofacial Pain, Fellow Faculty of Pain Medicine, ANZ College of Anesthetists, and a Fellow of the American Academy of Orofacial Pain. Past President of the ANZ Academy of Orofacial Pain, on the editorial committee of the Journal of Orofacial Pain and Headache. He's published numerous scientific papers and textbook chapters, and he really is an expert in the field. He lectures and teaches, and we're honored to have you on board. So I'm going to share Rob's slides.
Start the slideshow. Thanks, Ray. Great. Well, thank you. Can everyone hear me? Is the audio working okay?
Yes.
Look, I'm honored to receive this invitation to speak to this group, and I really find it a bit difficult to follow Bronwyn, who's such a fantastic lecturer and very difficult to follow. So I'm going to just basically give a broad view of orofacial pain, and then I'm going to zoom in, if you like, to the two most common causes of orofacial pain. And I think your group hopefully will find something useful from this presentation to go back to your practices and perhaps consider these alternative diagnoses to ENT causes of pain. Have the next slide, thanks. So orofacial pain now is a recognised specialty of dentistry in many countries, but not yet in Australia, New Zealand, and it's something that we're trying to work towards. It's a specialty of dentistry, and basically it covers the management of chronic orofacial pain conditions, problems with the temporomandibular joint. We're interested in oromotor type disorders that affect the jaw, and we really have a strong interest in treating these chronic patients that present to us. Can I have the next slide? Thanks. So this is an overview, and you can see we have two axes. Axis 1, physical conditions, and then axis 2 are the psychological conditions. So with our patients, we try and have this dual axis diagnosis, because a lot of these chronic patients do have comorbidities as far as the psychological conditions are concerned. And sometimes it's a chicken and egg type phenomena. So you see on the left there, the top is somatic pain, and particular deep pain, and then we can divide that into musculoskeletal and visceral causes. And the musculoskeletal causes include TM joint related pain and dental related pain, while the visceral causes of the dental pain, while you as a group will probably be dealing with the visceral type pains. Next slide, thanks. Now, there are international classifications that have been published, and this is probably the best one that covers orofacial pain. It doesn't include sinus disease, but it incorporates many types of orofacial pain conditions, including myofascial, TM joint, dental causes, and neuropathic causes, and we've got primary headaches in there as well. Next slide, thanks. As per Bronwyn's presentation, we're dealing here with a trigeminal system, and the trigeminal system, all of which converge, the three branches converge into the medulla oblongata and the brainstem, and where they mix in with cervical spinal inputs as well. So the message is that with this convergence, we can get pain referred from the sinuses and ENT, but from the TMJ and the teeth as well. And basically anywhere in this distribution, pain can be referred from one area to another because of this convergence into the same area of the brainstem. Next slide, thank you. The message I want to share with you is that pain can be generated from musculoskeletal, neurovascular, and neural causes. And as I mentioned before, referral patterns can occur anywhere within the trigeminal and cervical complex distribution. So we need to be aware of this. We need to be aware that convergence can occur and that over time we can get central sensitization if nociceptive information continues into that medulla area. This is important in the headache patients, I think, because perceptually, if you've got a more sensitized central nervous system, if you've got nociceptive input from another area, such as the TM joint or the neck or the sinuses, there may be what we can consider sensitization, which can cause easier initiation of the cascade, which eventually results in an attack of migraine. Next slide, thank you. I'm sure that this group will be aware that you see patients often refer to you with facial pain with a presumed diagnosis of sinus pathology. But in fact, clinical observations suggest that rhinosinusitis is an uncommon cause of orofacial pain. And I've just found a few studies there showing that 80% of patients with purulent secretions visible at endoscopy, in fact, do not have facial pain. And most patients with polyps don't have facial pain. And children with rhinosinusitis rarely complain of facial pain, even when there's purulent secretions. Okay, we can go. A significant proportion of patients who are candidates for endoscopic sinus surgery have symptoms that persist postoperatively. We're talking about pain. So I guess the basic message here is that many patients, including their primary care physicians, can mistake the facial pain as due to a sinus pathology when it's often not the case. Unfortunately, these patients often undergo multiple repeated consultations and can receive various treatments, including surgery. So, I guess my basic message is it's very important to distinguish sinogenic from non-sinogenic facial pain because we want to avoid erroneous invasive treatments such as surgery. Next slide. So as a broad view of orofacial pain conditions, we're looking at intracranial and extracranial causes, which the latter, which of course include innocent throat and cervicogenic inputs, but also dental inputs, inputs from the musculoskeletal system, which I'm going to be talking a bit about today. Then you have the neurovascular pains, which Bronwyn has spoken about. And then, of course, you have the neuropathic conditions, which can be divided into both episodic and continuous types. The most common being trigeminal neuralgia, which is in the episodic group. And then much more rarely the psychogenic pain patients. I find this is extremely rare in my practice. Next slide, please. So it's important to exclude non-sinus related causes before sinus surgery is considered. We need a multidisciplinary approach to diagnosis. Next slide, Ray. I'm sure I don't need to tell you about intracranial causes of orofacial pain and neoplasms, etc. So I'm just going to flip through that. Next slide. And Bronwyn mentioned the SNP4, so I'm not going to dwell on that either. She covered that, but I think it's an important mnemonic to remember for facial pain, and we need to rule out the worst conditions, and that's what this simple mnemonic helps you with. Next slide, thank you. So extracranial sources include the ear, nose and throat structures, the sinuses, but obviously there's other structures here which one has to consider and which are potentially causes of orofacial pain. Next slide, please. So my main goal here is a short talk, so I obviously can't cover every possible cause of orofacial pain, but I thought that this group would probably appreciate a bit more about odontogenic and TMD pains. Next slide, thank you. And it needs to be emphasized that the most common cause of orofacial pain is in fact odontogenic or dental pain. So when patients come in and you do your evaluation and you're not sure whether there's sinus pathology, in my opinion, the next most common cause would be a dental cause. And so ask your patients, do you have holes in your teeth? Are your teeth broken down? Are there fractured teeth? Are your teeth sensitive? So sensitivity, extreme sensitivity to hot or cold, which lasts, or to bite, this should raise the suspicion for a dental cause of the pain. Another one is the pain is waking at night. There are very few conditions, and Bronwyn can probably mention a couple of headache conditions, including hypnic headache. But dental pain is one of the few pains that actually can wake people from sleep. Dental pain is often missed by medical people, and it basically involves inflammation of the pulp, which can lead to pulp necrosis. By contrast, gum problems are usually relatively painless. Next slide, please. So please have a look in the mouth. Look for holes, look for broken down teeth. Maybe just tap your teeth with a mirror handle if you have one, or percuss the teeth. Check in the mouth for swellings that could suggest an abscess formation. Have a look for sinus drainage, which usually occurs through the buccal plate, the buccal mucosa of the maxillary or mandibular teeth. If you're not sure, order an OPG, a cone beam CT, or possibly a CT dental scan, which is far more specific for dental pathology. Next slide, thank you. So this just shows a slide about the stages of dental pulpal pain. Normally, the teeth do respond to electrical and cold stimuli, but when that is applied, there's an immediate response which basically resolves straight away. If you have hyperemia that follows an insult to a tooth pulp through trauma or caries, there's a hyper response. So putting cold on these teeth, or hot especially, will cause an exaggerated response which lingers as distinct from the healthy tooth. And if you have spontaneous pain, that usually indicates a very high degree of inflammation and ischemia, which can lead then on to pulpal necrosis and ultimately abscess formation. The dental caries is the most common infective disease in humans and affects a very high number of people. And I was actually at a quiz night last year and they asked this question, what's the most common infective disease? And I actually didn't even think of caries, which is a bit, for a dentist, that's a bit weird, I know. Next slide, thanks. So toothache is the most common orofacial pain complaint. 12% report toothache in the last 6 months. Remember that pain from one tooth can be referred to another tooth or from other orofacial structures. And this can include the sinuses, of course, where a sinus infection or inflammation can cause pain in the maxillary teeth. It can be a throbbing pain or a dull pain, usually made worse when the patient stoops forward. And remember that other pain disorders, including migraine, can cause pain into the teeth and vice versa. It can be quite difficult to diagnose. I've had patients that have had multiple sinus surgeries. They've had all sorts of invasive procedures. One patient had eye surgery, and the ultimate diagnosis was from a tooth, pulp that had degenerated. So pain can be referred in any direction, really, up or down, usually. Thanks. Next slide. Next slide. Thanks. Yeah. So, sorry, just go back one. I'd like to sort of make the strong point here. You should consider all pains in the mouth and face to be of dental origin until proven otherwise. It's a fairly strong statement, but again, I stand by the fact that the teeth are the most common cause of orofacial pain and should always be considered. Next slide, please. And here's a OPG taken of a patient who's had endodontic treatment in every tooth in their mouth. Absolutely ridiculous and clearly misdiagnosis. This is just a shocking case of overtreatment. Next slide, thank you. So moving on from the teeth, the next most common cause of orofacial pain are the musculoskeletal pains, and in particular the temporomandibular disorders. So these are conditions that affect the TM joint and the related muscles of mastication and the related tissues. I like to remind medical audiences that temporomandibular disorders is a collective term. It's not one disorder. So when patients come to see me and say, well, I've been diagnosed with TMJ, I say to them, well, that's like being told that you've got knee. The TMJ is the joint, okay? Temporomandibular disorders are the range of conditions that can involve the TM joint. And as mentioned before, it's a major cause of orofacial pain, and it's probably the major cause of non-dental pain. Thank you. So the common symptoms are shown here, headache, ear, jaw pain in particular. There can be neck ache, again, related to the convergence into the same area of the brain. And there can be catching, locking of the jaw and clicking and popping sounds. Next slide, please. These are the primary clinical features which are common to the temporomandibular disorders. And that doesn't mean that every temporomandibular disorder has all of these. But the common ones are preauricular pain, obviously in the region of the TM joint. Pain is aggravated or caused by jaw movement and function. Patients present with tenderness in the TM joints and related muscles of mastication. Patients report restriction or difficulty with jaw movement, and they often report TM joint sounds. In the younger group, it's more clicking noises, but as time goes on, there may be more crepitation and cracking sounds. Next slide. Related symptoms include headaches, ear symptoms, particularly sensations of discomfort and fullness in the ear. Some patients report subjective hearing loss, but that's what it is. It's subjective because usually audiology is normal. These patients often feel that their bite has changed and their jaw movements are shaky, and sometimes they report swelling, but usually swelling is not a strong clinical feature. Next slide, please. The real sine qua non diagnostic feature of temporomandibular disorders is that the pain or dysfunction should be directly related and aggravated by jaw use. Next slide, thank you. The taxonomy of temporomandibular disorders can basically be subdivided into the articular disorders, that affecting the TM joint itself, and also masticatory muscle disorders. So when the patient comes in, I'm usually trying to distinguish which is the primary source of the pain. Is it arthrogenous or is it myogenous? Sometimes it's a combination of the two. TMDs do not include trauma, infection, neoplasia, or neuropathic pain disorders. Next slide, thank you. So is this common? It's all very well me talking about it and saying that it's common, but it is common in a younger population. And Bill Solberg, who is my mentor at UCLA, did a study of college students, and he used to grab them as they walked past the health centre building at UCLA, and he'd ask them whether or not they had any of those clinical features that I mentioned in the previous slide. And in fact, 76%, 3/4 of young adults, had at least one sign of TMDs, and males and females. However, with further questioning, like how severe is it, does it bother you, etc., those that had more severe, that would require them to visit a dentist or a doctor, was only about 3 to 5%, with females much more common, 8-to-1, which sort of corresponds with what I see in my practice. Other studies have been done since. This was a Dutch study by Dr. Delcanho, studied 3,500 people, which is pretty good study for those of you who've done clinical research, and 1 in 5 reported previous or current problems. But 85% of that group did not feel they needed treatment. 15%, the other 15% had consulted a doctor, but only 6%, which is quite similar to Solberg's findings of around 5%. And another study done in Minnesota looked at the most at-risk group, which are generally considered to be females in the childbearing years. 65% had either an articular or masticatory muscle problem, but again, 7% had severity comparable to those being seen in the clinic. So I guess the message is that it's common, but maybe 5 to 7% of the population have a TMD that would probably require some assessment and management. Next slide, thank you. Looking across studies, the prevalence varies. There was a study in the US, estimated 4.8% of US adults had or had pain in the region of the TM joint. So it's likely it's a prevalent type of chronic orofacial pain, can be acute as well. And it's comparable in prevalence and related to other chronic pain conditions, such as migraine fibromyalgia syndrome. Next slide. This was the age and sex distribution. You can see that women outnumber men, and between 15 and 45 years old seems to be the major distribution of patients presenting with temporomandibular disorders. Next slide, please. There have been some recent advances by international consensus looking at how to diagnose the various temporomandibular disorders. And this group has come up with diagnostic criteria, which of course you can access via this website. And there's both a physical and psychosocial assessments for these patients, and with the access to psychosocial assessment particularly important in the chronic group. Thank you. Next slide. So as mentioned before, we've got the temporomandibular disorders, which can be subdivided into myalgia and arthralgia, but also there's headache, which is secondary to TMD, which Bronwyn might have seen some of these patients. And then you have these intra-articular disorders, which may or may not be painful, associated with clicking noise, usually painless or minimal pain, but this can progress to locking. And then, of course, you have the degenerative joint disease group. Next slide. Thank you. This is an example of the diagnostic criteria from that group. So this is looking at arthralgia, TM joint arthralgia, and you can see that it's quite specific, pain of joint origin affected by jaw movement and function. Replication of the pain occurs with provocation testing of the TMJ, that is loading tests, palpation, etc. Patients have a history of pain, and the pain is modified by jaw movement and function. Next slide, thank you. So these are the muscle disorders, which are probably the most common type of temporomandibular disorders. And you can see the slide on the right there, the muscles that are involved are temporalis, masseter, and the pterygoid muscles. And what this group has done is subdivided myalgias or muscle pain into local, that is just pain in a local spot, myofascial pain, which involves the whole muscle to the boundary, and then myofascial pain with referral, where palpation of this muscle may lead to pain in a distant site. Muscle pain is generally of a dull, heavy, aching type, affecting the jaw region, can affect the teeth as well. Aggravated by jaw movement and function, there's tenderness, and patients report that their jaw feels fatigued and weak when they do their chewing. Often there's a temporal headache component with these patients. Causes: trauma, stress, habits, tooth clenching and grinding, bad habits with the jaw, such as chronic nail biting, chewing gum, beef jerky, ice blocks, these sort of things. In my experience, stress and anxiety and tension with sleep disturbance and bruxism is often a related cause for these patients. Next slide, thanks. So this shows some of the referral patterns that have been identified. So this is the masseter muscle. The crosses show the tender points, and the dark areas, the stippled and dark areas, show where pain can be referred from these muscles. So you can see that the upper part of the muscle can refer pain into the upper teeth. Lower down in the muscle can refer pain into the mandibular teeth. There can be sort of broad diffusion of pain, which can include the maxillary area and lead to temporal headache as well. So that's the masseter muscle. If we just do the next slide, it's got the temporalis. The temporalis muscle, go back one. So anterior temporalis can refer pain across into the sinus area and into the upper teeth. Depending on where the tender point is, refers pain to different areas. So I'd recommend that your group consider palpation of the muscles of mastication to see if palpation can actually replicate the pain of this patient. So looking at dental pain and myofascial pain as referring into the sinus area. Next slide, thanks. There's a lot of research going on now, particularly into the chronic group, and it's seeming more and more obvious now that chronic TMDs are probably part of a generalized pain disorder, which can include more widespread pain conditions, overlapping pain conditions, with significant impact on the individual in concert with chronic pain elsewhere. Next slide, thank you. This was a study from Sydney, a Chris Peck's group, and he asked these patients presenting to the clinic to do a pain diagram. And these were a fairly chronic group, and you can see that a large percentage, 60% of them, actually had pain in other areas of the head, but also the back of the head and shoulders and down into the neck area. So TMD has been associated with a number of other chronic pain conditions and can be, at least in the chronic group, be considered a generalized pain disorder. Next slide, thank you. Comorbidities are more prevalent in people with TMDs than the general population. This can include migraine, chronic fatigue, irritable bowel, restless leg. TMD patients with comorbidities are most often females. They more often have a muscular basis to their TMD, and often there's comorbid depression and anxiety. Next slide, thank you. Diverse clinical manifestations. TMDs are associated with irritable bowel, fibromyalgia, and chronic fatigue syndrome. And there's the non-pain symptoms such as fatigue and sleep impairment, cognition, and affective disorders. Next slide, please. So these are some of the conditions that are associated with chronic temporomandibular disorders. And really we call them now chronic overlapping pain conditions, but basically they reflect central sensitization disorder, often on a background of stress and anxiety and depression. The question is, which came first? Next one, thank you. There's a strong association between myofascial muscular TMDs and headaches, in particular tension type headaches and migraine. A very high percentage of TMD patients have comorbid migraine. And we're looking at the other direction, migraine and headache frequency are associated with painful TMD symptoms as well. So basically, the presence of one condition should raise suspicion of the other and warrants collaboration between healthcare practitioners such as neurologists and orofacial pain specialists. I find myself constantly teasing out migraine with my TMD pain patients. Thank you. Next slide. So what sort of questions can you ask in your practice which may raise in your mind a suspicion that this patient has a temporomandibular disorder requiring further assessment and management? So these are the 9 questions that you can ask, but the 3 top ones are the most important. Do you have difficulty and or pain when opening your mouth? Does your jaw lock or get stuck? Do you have difficulty and or pain with chewing, talking, or otherwise using your jaw? So these 3 probably are the most diagnostic. These other 4 to 9 are probably less important and are associated. I'm not really too concerned if a patient says, well, I've got a clicky jaw, for instance, but if they have frequent headaches, of course, that's not specific for a TMD, but I want to know about frequent headaches. So questions 1 to 3 there, if you have a positive response, you should think that a TMD is highly likely and probably refer to an orofacial pain specialist. Next slide, thank you. What about an exam? You can do a screening examination very quickly. And the first thing to do is ask the patient if they can open their jaw and measure it. You can just use a simple ruler from a steel ruler, from a hardware store. And you want the patient healthy in general to be able to open their mouth to 40 millimeters as measured between the edges of the teeth, as shown there in that slide. If they can't open to 40 millimeters, it should raise your suspicion something's wrong. And as far as moving the jaw laterally, you want them to be able to move their jaw about 8 millimeters. So while they're doing these movements, ask the patient, do you have pain? Ask them to point to where the pain is. Is it at the TM joints or is it further forward in the muscles of mastication? And while they're opening their jaw, have a look. Is their jaw opening straight or is it obviously going off to one side? So that's the range of movement. You can do that very quickly. I then palpate over the TM joint itself. Don't press too hard. You only want about the pressure required to blanch your fingernail if you press down on it on a table or something, and press the TM joint capsules, and also press the masseter muscles and temporalis. Next slide, thanks. So, what are the take-home messages that I really wanted to convey today? Please always consider, and I'm sure you do, non-ENT related orofacial pain conditions. Remember that chronic sinusitis is rarely the cause of orofacial pain. Orofacial pain is most likely due to odontogenic, that is dental, or musculoskeletal causes. Because of time, I haven't had the opportunity today to go through neuropathic causes, but obviously they should be considered. But I'm really just wanted to talk about the common ones today. You can do a thorough history, as Bronwyn Jenkins mentioned. It can include imaging and screening blood tests. And basically consider that orofacial pain in general should require a multidisciplinary approach with multiple healthcare specialists. I'd like you to be aware of the role of other specialists in managing orofacial pain, particularly where the cause is not related to the ear, nose, and throat structures, and be comfortable referring patients to the appropriate specialists. Next slide. So thank you very much. I've really zipped through that. I hope you find things of value there, and I'm open for questions as well. I hope that's what Raywin and Ray were looking for.
Thank you very much. Richard, did you want to ask your question in person?
Yeah, no, it was a great talk, Robert and Bronwyn. I really enjoyed it. I'm based in Sydney and a rhinologist, and I think I've seen every facial pain syndrome, but usually after about 3 or 4 operations. And I wanted to ask you, for me, if I had to say, what was the obvious thing that was clearly not, it wasn't sinus to begin with, it was the complete lack of other mucosal based symptoms. And perhaps, Robert, you touched on psychogenic pain. The patients have this strong sense of maltreatment or harm was done to them, some sort of mistreatment. But I'd love to know from you, Bronwyn and Robert, when you see patients and they've had sinus procedures done, in hindsight, what are common themes to you that it's very clear that this probably was never a sinus disease in origin? You talk about your flags, but they're flags for you guys to pick up when it's not a cathalgia. I would say that surgeons need, what are the flags for surgeons that it's not sinus, it's something else. It's almost the opposite that we really need as a profession. Love to hear your thoughts.
I ask a really simplistic question because all my patients tell me they have sinus disease, all of them. And they tell my nurse and she buys it hook, line, and sinker, and then I sweep through after. And so I ask them whether their sinus symptoms come on just the headache days. And it's the same with neck, it's the same with jaw, it's the same with all the structures that share the common pathways. I ask them whether they only have their sinus symptoms on their headache days or whether they have 2 weeks of nihilistic sinus issues with green snot that needs antibiotics. So that helps me a lot. But obviously, we're talking about the more difficult ones. And I think in the ones that end up, and some of them are sensitized, like Rob was talking about, this really important topic. And so we're never going to win. But the ones that are clearly they were migraine and therefore exhibiting more symptoms than they should have are worse with exercise, triggered by smells like paint, triggered by alcohol or hormonal factors. So, a sinus packed full with the wrong structure is going to be a much more persistent disorder. So the other thing is the impersistence, so that episodic variability. So likewise, I have patients that come to me and go, oh, I've come to you about my migraine. And it's like they're constantly sensitive. I just finished a letter that tonight are constantly sensitive to light or noise. And I'm like, that's not right, because migraine is a fluctuating disorder. You have good days, you have bad days, even if you're having daily headache at the end of the day. So look for impersistence, look for typical migraine triggers, and look for the pain in the head associated with the other symptoms they're complaining about because of the autonomic activation from the pain centers.
Yeah, I agree 100% with Bronwyn, of course. I'd be very hesitant to disagree with.
I'm a black belt, so yeah.
Yeah,
So,
yeah. I mean, I think if the initial surgery hasn't worked, I don't know that it's a good idea to go back and repeat the surgery. I would be looking for other things, and my concern would be, unless you've got really florid sinus pathology, my recommendation would be to ask about dental, ask about musculoskeletal, ask about migraine, and you're gonna find a lot of patients are going to have symptoms related to that. I've seen patients that have had 3, 4, 5 sinus surgeries, and it's beautiful, beautiful work, plumbing work if you want to call it that, and they've still got they've got chronic pain, and my concern is that damage is being done to the trigeminal nerves or branches of the trigeminal nerves during these surgeries. So then you've got like a further problem where you've got neuropathic pain as a result of nerve injury. But I think Richard, if you can cover the dental and the musculoskeletal and the migraine, you're going to catch a vast majority of patients. Obviously, there's more rarer conditions, but I think we've covered the most common ones here that are not sinogenic pain. Does that answer your question?
Yeah, no, I absolutely. And the only thing we didn't touch on then, what do you have? What do you do with a patient that, it sounds like it probably wasn't sinus related. They are your patient that's had now 3 or 4 surgeries, but during the course of their care, it's morphed into now my pain is because someone's done something wrong to me inside. So
Mm.
even though they presented with pain to begin with, it's now somehow morphed into a consequence of their intervention. And you only have to walk into any chronic pain clinic in a hospital, and it's because of my laparotomy, because of my back surgery,
Yeah,
because of the knee surgery. Like, how do you manage that situation where no one buys those procedures without there being pain
yeah.
to begin with? Yeah.
But I'm sure you'd accept that every time you go in, you are dealing with nerve endings of the trigeminal nerve that are going to be traumatized. They have to be. So there is the potential for nerve injury with any surgical procedure, and there's a vast literature on this. And so that's why I said my concern would be with the more surgery someone has, the greater risk they have of neuropathic, continuous neuropathic pain. It happens in the mouth. People have multiple teeth out and they have root canal treatment and they have wisdom teeth extractions and they're left with pain. And that's more than likely, I'm talking about chronic pain, persistent pain, more than likely it relates to nerve injury. Maybe Bronwyn would like to say something.
yeah, my world's a bit of a happier world because I've got lots of drugs, lots of drugs. So if it's a neuropathic pain, they respond really well to something. So at a decent dose. So there's a lot of coaxing and encouragement, but if they can be on a big therapeutic dose of gabapentin, that they'll end up being happy. If it is the nerve fibers, a lot of the people that are unhappy that they've had the procedures and their expectations weren't met had unrealistic expectations and had functional neurological symptoms to start with. And I have really clear expectation setting plans and discussions with the patients that are shared with the patient and the doctor from the first consult. So I have patients that come to me that are the incurables that have tried all these fantastic drugs I was touting, and they still sometimes they're not the happiest person in the room, but because they walk away with me saying, look, I think it's functional neurological symptoms. Look at this website, www.neurosymptoms.org. And you need complex psychological care. And I use a lady called Kathy Ebbett on this side of the bridge, on the north side of Sydney, and there's another one over in the RPA sort of region. So They're different care, but there's someone out there for all these head types. So if it's not responding to surgery, I would find your local friendly headache specialist. And I've spent the last 8 years educating people to hold your hand and get them to have realistic expectations and therefore realistic outcomes. The third group, so the group that didn't, have nerve pain and didn't have unrealistic expectations because they were mad to start with. I'm aware that this is being recorded, but only to health professionals. But the third group, where you go, oh God, I think it might actually be really weird migraine. They still end up happy because they get on the migraine treatments and they're just can never thank you enough for sending them to that person and being on better treatment. So I think there's a treatment for every person. So if it doesn't smell right, all of our groups. So I loved the multidisciplinary approach of Rob's talk because it's exactly what we do. We don't have to be co-located. We don't have to be colleagues working under the same practice and sharing the same admin. Most of multidisciplinary care now in this era is not co-located, and it's diverse. So I see people interstate and still liaise with their psychologist and their physio and whatever is needed. So so reach out and I'm not the only headache specialist in Sydney, but you shouldn't be left holding the bag of patients that we're never going to improve with surgery and coaxing you to do more and more things that will end up only being harmful if they're not going to help more than they harm. Yeah,
Yeah, I mean that was the group that I was touching on. This
yeah,
group that perhaps had functional symptoms to
yeah.
begin with, and it's just a downhill cascade. More.
Questions, yeah.
So, analogous thing that's happening in the dental world is implant surgery. So I see patients who have had implants placed, in their maxilla or mandible to replace lost teeth, and there's been nerve injury. And these patients are very angry, and they're looking for legal compensation, and so it's not, I'm placed in the position sometimes. Well, gee whiz, what can I do with these patients? And one has to tell them that surgical procedures can have consequences, but one hopes that they've been given good informed consent beforehand that there is a risk of nerve injury. Okay. Sorry. Yeah.
Oh, thank you.
I think one of the best talks I ever went to was at the International Headache meeting where the speaker at the end of their talk was being hammered by questions. And in the end, he broke and he said, remember, there's some patients we just can't help. And I think that the number of patients that we feel like that about are less and less and less, because I do believe that almost all patients, as opposed to 20 years ago, have something out there for them to make them half better. But sometimes we all break and we're left holding the bag of someone who's not going to get better with what's in our armamentarium, and so we need to get them into the other areas.
It's hard to get patients into psychologists and psychiatrists, though.
I just tell them that I have no magic wand, and
Yeah.
that this is, but also I think really important is to not minimize it or say this is not a
No,
disease.
no.
These are the worst patients. They become highly disabled, highly angry, highly resistant. And so literally this afternoon, I got this huge thank you text. I was like, who's this? From another neurologist who's like, thank you so much for this letter. Because this guy came in, he's mad as a cut snake. Literally, this is not a primary headache disorder. This is clearly functional neurological disorder. He's had every test, he's had every treatment. He hasn't responded to any. They've made him worse, of course. And I've just been very clear. I've been clear in the plan that was discussed with him at the moment, and I've been very clear in the summary paragraph, and I've copied it to him, and I've copied it to the doctor. The doctor's just so grateful that now he's got a plan that he can get on with complex psychology treatment, stop being medicalized, stop being kept in the loop of investigations and a scan for their sinuses or whatever every single time, and actually move on with the fact that it's not the sinuses. So I love that in your specialty, I think you can stand back and go, it's not your sinuses, it's something
Yeah.
else. Let's go look at the other things.
Yeah. Don't
It's
forget the
great that the
multidisciplinary
neurologist
patient.
felt that, but
Yeah,
whether the patient accepts it,
that's
that's a
okay.
that's
We're
a
not
different
there to
story.
make friends. Most of our
So,
patients love us, and not all of them need to love us. It's like being at school. Not everyone needs to love you, you know?
Yeah. But the chronic pain clinics, the multidisciplinary pain clinics within the public hospital system, I think that's probably the best place to try and get these patients into, although the waiting list can be long, because they're equipped to do this with psychiatric and psychological people to help out.
Yeah, so the Northern Pain Centre in Sydney have psychiatrists and psychologists involved, and I go, well, this is a psychologist with pain interests, and their patients are happy. They're like, oh, good, I'll go talk to them about my pain because you're
Yeah.
not giving me enough airtime. So there's
So don't
services
forget
out there.
them. Yeah.
Anyone else with any questions?
Hmm.
All right. Thank you both
You're welcome.
for your time and your wonderful talk.